Thank you so much. And I'd like to thank the foundation for this opportunity. You know, we go to our national meetings and our regional meetings, and we do it in our field of interest, and we enjoy it and we learn incrementally. But for me as a cardiologist to come to this meeting, I feel like a kid in a candy store because of all that I've learned, and I hope in the next 30 minutes I'll be able to give a little bit back. I'm only going to only touch on 3 subjects as they pertain to the heart in Dravet syndrome. The first is something that was touched on early this morning, and that was the topic of fenfluramine and possible damage to heart valves. Next, I'm going to talk about something that's going to be sort of fun to talk about. It's something that does not have much basis in Dravet syndrome as far as we know, but we'll talk a little bit about the voltage-gated channels that are active in both the heart and the brain, the various syndromes, including Dravet syndrome, and how the coexistence of certain channels in both may have relevance to this population. And then finally, something which is still theoretical but may have great importance in Dravet syndrome, in particular in SUDEP, and that's heart rate variability and its relationship to the underpinnings of Dravet syndrome, which is the voltage-gated sodium channel problem. In 1997, New England Journal came out with this blockbuster article on 20-some-odd obese individuals, I believe they were all women, who had been taking fen-phen, which is fenfluramine and phentermine, to knock down their appetite for weight loss. And these individuals all showed up with heart valve disease, especially abnormalities of the right-sided heart valves, the tricuspid and pulmonary valves, with leaky valves, obstructed valves, and or pulmonary hypertension. And the pathology bore a striking resemblance to what's seen in Carcinoid Syndrome, which is a disease of neurosecretory tumors, neuroendocrine tumors, which release a variety of chemicals, most notably serotonin. It has since been learned that serotonin upregulates various growth factors, including fibroblast growth factor, resulting in these fibrous caps which occur along the fibrous skeleton of the heart, and especially the tricuspid and pulmonary valves. Phentermine, which was part of fen-phen, decreases the degradation of serotonin in the lungs, amplifying the effects of the serotonin. Disturbingly, when you look at the doses of fenfluramine which are being used in Dravet syndrome, they're not terribly much lower than the dose per kilogram of body weight of fenfluramine that was used in the fen-phen preparation. But that only tells a portion of the story, because the 0.2 milligrams to 0.7 milligrams per kilogram dose of fenfluramine that's being used clinically in Dravet syndrome is on a per kilo basis. And you can't really compare that to the huge doses that were being used in obese people, even though those doses were in the 0.6, 0.7 milligrams per kilogram per day in those obese individuals. That's because they were very large. They had BMIs of 30, 40, 45, 50. And so they were getting enormous doses, just not so much on a per kilo basis. So the amount of fenfluramine that is being used in Dravet syndrome probably is substantially less at a biologic level. And across the spectrum of studies that have been done looking at the effect of the side effects of fenfluramine in this population, none have shown any valve diseases, the valve abnormalities. The expected side effects are the decreased appetite, some GI symptoms, and then some very non-specific symptoms. When you look at that particular study that I just outlined, a second spin-off project from that experience of over 230 Dravet patients showed that there were zero valve disease or pulmonary hypertension in them, but what I want to highlight is that the duration of follow-up is only less than a year. And so I think that the current recommendation of twice-a-year echocardiographic monitoring of these patients who are on fenfluramine is probably prudent for the time being. So I want to change gears to something that's going to be kind of fun to talk about. These are my homespun slides showing cartoons of how the heart works as regards voltage-gated channels. In your world, voltage-gated channels are responsible for neurotransmission of various neurotransmitters, GABAergic, dopaminergic, and so forth. So sort of like all the roots and all the trees in the planet Pandora from Avatar, they all talk to each other in that chemical way. Our world's a little bit different. What happens in the heart is voltage-gated channel depolarization, which heralds more different channels to open in a very sequential, orderly, and synchronized way, which then results in mechanical contraction of the myocytes, so-called electrical mechanical coupling. And so in the next few slides I want to show that. The aqua figure in this figure is the idealized ECG. So you recognize the QRS and the T wave. In this picture of three myocytes linked together by passive channels called gap junctions, the sodium ions are depicted in yellow, calcium in red, and potassium channels in purple. And so when the sodium ions from one cell passes along to the next cell, that causes slight depolarization, resulting in the opening of the SCN, not 1A, but 5A channel, causing rapid depolarization. As the transmembrane voltage changes just a bit, calcium channels begin to open, completing the QRS, and then opening outward potassium channels, which begins the ST segment, and then finally the T wave, completing the process of depolarization, repolarization. Then there's some energy requiring processes that get the sodium and the potassium back to where they started, ready for the next event. So that's what happens to get sodium into the cell, and then more importantly, calcium into the cell. There is a high density of calcium channels along the canal-type structure that we call the T-tubules in the heart muscle cells, which then encircle the major calcium reservoir of the heart, which is the sarcoplasmic reticulum, or SR. Interestingly, next to this big clustering of calcium channels at the T-tubules are also, at least in rodents, are SCN1A sodium channels. So there may be some link. So what happens during depolarization in this large clustering of calcium channels in these T-tubules is something called the calcium-induced calcium release mechanism, where the calcium then attaches to an important receptor called the ryanodine 2 receptor, which then opens up the huge calcium stores in the sarcoplasmic reticulum, which find their ways to the contractile proteins, the troponin system, and then all of its downstream proteins, which results in interdigitation of the myofibrils. The heart cell shortens, and when all the heart cells shorten at once, you get a heartbeat. So here I've taken you from voltage-gated ion channels to contraction of the heart muscle cells. A little bit different than what goes on in the brain. and yet there are some commonalities which I'll talk about. The calcium eventually gets taken back up into the sarcoplasmic reticulum, again, making us ready for the next beat. So who cares? Nice cartoons. It was fun putting these slides together. We care because if there is either a gain of function or, more commonly, a decrease in function of some of the products of some of these genes that code for these various channels, it will disrupt the orderly process that I've just described, which will then, in a very heterogeneous way, result in changes in some of the cardiac cells, but not other of the cardiac cells. And what that does is, much like throwing a bunch of rocks in a stream, eddies of water will cause eddies of electricity, which encircle the rocks, so-called re-entry, which can then result in a very rapid and potentially fatal heart rhythm, which is ventricular tachycardia. All because of heterogeneous abnormality in certain voltage-gated channels. Analogous to Dravet syndrome, when there is a decrease in the SCN5A gene versus the SCN1A gene in Dravet syndrome, you will have a decrease in sodium channels product in the heart, which can result in a syndrome called Brugada syndrome. And I'm going to come back to that in just a moment. The figure here is an idealized version of something called long QT syndrome, which is caused by either a loss of function in certain potassium channels or a gain of function in the SCN5A channel. In Brugada syndrome, which is far closer to Dravet syndrome, you have a decrease in function of sodium channels, which can result in the QRS as seen in the lower left portion of the figure. This will result in heterogeneous depolarization across the thickness of the heart from the inside lining cells to the outside lining of the cells, causing a voltage gradient, and again, like the rocks being thrown in the river, water or electricity will spin around, causing a potentially fatal heart rhythm problem. There are a number of, and I'm not going to go through all of these, it's a busy slide, I recognize it. It's just to make the point that there are a number of ion channels which are predominantly brain, but also exist in lower levels in the heart in animals and even in humans. And there are a certain number of ion channels which control the mechanisms I just showed you in the previous cartoons, which exist in lower levels in the brain. So the opportunity for crossover is significant. I want to direct your attention in particular to the lower portion of the slide where you see KCNH2, which is a very serious form of long QT syndrome. The KCNH2 channel also exists in the human brain. And unlike all other forms of long QT syndrome, there's like 17 or 18 different forms now. This type, or long QT type 2, has a much higher likelihood of having primary epilepsy, in addition to the risk of sudden cardiac death from cardiac rhythm abnormalities. This slide simply shows the family of sodium channels that exists in the heart and or the brain. I have emboldened those channels which exist in both the heart and the brain, and in red you see some of the syndromes which are a result of mutations in some of those genes. The SCN1A right at the top is Dravet syndrome and certain others. And then as you go further down, you'll see SCN1B, which is the beta subunit of the SCN1 channel, which also can result in Dravet syndrome, but also one of the Brugada syndromes, which I just showed you, which can result in a malignant cardiac tachycardia. Animal studies have in fact shown, at least in mice and rats, a significant endowment of the SCN1A gene, which can be very active in the sinus node, which is the natural pacemaker of the heart. The SCN1A gene is blocked by tetrodotoxin, but the cardiac sodium channel, SCN5A, is not. And as you can see, that's a little mouse EKG at the bottom. And at the bottom left, you see a normal heart rate in a mouse. And in the right, you see in mice who have been pretreated with tetrodotoxin, which is not going to affect the SCN5A, but it will affect the SCN1A, you do see the slow heart rate or bradycardia. In this Mayer's another study by Mayer's lab, you see a pretty heavy endowment of the SCN1A gene active at the T-tubules of myocytes, cardiac myocytes in those individuals. And then you see in the middle bottom, you see the flat line of what happens to depolarization in those myocytes, in those channels, when pretreated with tetrodotoxin. And this has the additional deleterious effect of decreasing contractility of the heart, which you see in the lower right. So we've known for a long time, for over 20 years, that there are heart rate changes in a variety of clinical epilepsies. And it can be fast heart rate or tachycardia, slow heart rates, bradycardia. It can vary in a diurnal pattern. It certainly can be accentuated during and especially following seizures, with bradycardia seemingly to predominate. But the correspondence of serious life-threatening rhythm problems with sudden death has been elusive in all but just a few case reports. And so we really are having a very difficult time. I feel like the guy who's trying to grab a curtain with my left hand and another curtain with my right hand and trying to pull them together, and they're just really not coming together. So what investigators have done with newer technologies is that we have tried to create a platform where we can monitor serious heart rhythm problems over a very long time horizon. Thanks to the pacemaker industry, we have something called insertable loop recorders, and you see at the top what the newest version of it looks like. You can see the size there in an adult hand. The way it is injected is through a plastic device which has got a little cradle. You see the ILR or loop recorder in the cradle, and using a plunger, it gets pushed over a plastic sort of a shoehorn through a notch, a nick that's been made in the skin, to the subcutaneous tissue in the chest. And there it sits, and it has a little battery in it that will last north of 3 years, and it can be programmed to automatically record the heart rhythm whenever the heart rhythm suddenly goes at a specification. In addition, patients themselves or caregivers can click over it with a non-attached device and sort of bookmark the heart rhythm at that moment in time. In a pretty good-sized study of 20 adults with focal epilepsy, this device was used over a fairly short time period, only 18 months. It was one of the older devices. And they did find that during seizures, there was a general increase in heart rate, but not in a pathologic way. And there were also 8 patients who had bradycardia. And of those 8, 4 of them actually received pacemakers. Now, did they need pacemakers? We don't know. The idea that somebody's heart rate would get very slow and even stop for several seconds, which you see in that middle portion, isn't that huge a deal. I guarantee you 30 to 40% of you have fainted at one time or other in your lives. And I also guarantee you that 10% of those of you probably had a heart rate that stopped for several seconds. That's a vasovagal event. And you didn't get pacemakers for it hardly ever. So it's unclear what this data really means. In a small group of patients in our institution, 14, we've also implanted devices in this device in patients with Dravet syndrome. 13 of the 14 had SCN1A, the other had an SCN1B mutation. The median duration of follow-up is just over 3 years. The criteria that has been programmed into the device, it will automatically record any heart rate greater than 220 beats per minute for at least 16 beats, or a heart rate less than 30 beats per minute, also for 16 beats, or any pause greater than 3 seconds. And 12 out of 14 for whom data is available, there have been 0 individuals who have had any abnormal rhythm fulfilling those criteria. So far, there's no useful information. But in terms of the risk-benefit calculus that goes into all of our decisions that we make every day in our clinical practices, it is a low-risk, potentially high-yield tool. So to that point, it's been a hard sell to say that there's a primary cardiac rhythm disturbance in our Dravet population to account for SUDEP. So in the last part of the talk, I want to talk about something that I think really may have some real-world benefits to our population in the near to moderate future. And that is to harness the information available from monitoring of heart rate variability. So heart rate variability doesn't refer to how much the heart rate changes overall, but rather patterns in heart rate change. If you feel your pulse and you breathe in and out slowly, you will notice that your heart rate speeds up a little when you breathe in, and it'll slow down a little bit when you breathe out. That's called respiratory sinus arrhythmia, and that is very much under control of a nerve called the vagus nerve. That periodicity of that is the periodicity of how often you breathe. So that's what, 10, 12, 14, 16 times per minute, or about 0.4, 0.3 hertz cycles per second. That's considered high frequency. That's a high frequency variability in the pattern of your heart rate change, and that's indicated by those widely separated green arrows at the bottom of the slide. Rather, the closely spaced green arrows at the bottom of the slide. Sorry. Now, there are other patterns that occur over the course of the day that are under the influence of other components of the autonomic nervous system, including sympathetic nervous system drive, but also including non-neural patterns, such as the renin-angiotensin system, and probably other metabolic patterns which occur in a diurnal pattern. But if you measure somebody's heart rate variability with Holter monitoring in somebody who's had a heart transplant, you'll see a fairly flat line, meaning that virtually all of the heart rate variability is at the behest of the autonomic nervous system, because of course the heart transplant recipient doesn't get the nerves, he only gets the heart. There may be some renervation over time. So the way this is done is that a monitor is placed on the patient, and you can get some heart rate variability information in as little as 5 minutes of monitoring, but more often we try to do it over a full 24 hours. And then the computers are very powerful, and they're able to look at a variety of measurements that I'm not going to go through that are in what's called the time domain, and it's basically looking at the change in interval between heartbeats from beat to beat to beat in all patterns therein. Using something called a fast Fourier transform, frequency domain information is also available in the high frequency range, which is predominantly caused by vagus nerve influences, as well as low frequency, very low frequency, ultra low frequency, although the contribution to heart variability of the others is pretty low. So it should be pretty obvious where I'm going with this, right? So the autonomic nervous system has as its anatomic basis the brainstem and all the upstream information that goes into the brainstem. And we know that the parasympathetic nervous system has as its ganglia structures very near the target organs, whereas the sympathetic nervous system has its ganglia along the sympathetic ganglia and the dorsal root ganglia. And so it's pretty clear that since there is such a high endowment of postganglionic nerves to the pacemaker of the heart, the sinus node, that we get a lot of very indirect information about autonomic nervous system function from heart rate, structure, and function. This information has been looked at in a number of studies, comparing, in this one, and this is in Delagou's study, which has been really widely praised, because they carefully looked at both Dravet patients as well as patients with epilepsy on anti-epileptic drugs, as those not getting anti-epileptic drugs, and control population. And the Dravet population does seem to show a significant imbalance, overall reduction in heart rate variability, and especially in imbalance sort of tilted toward decrease in function of the parasympathetic nervous system. In our group of 12 patients who we have, 14 patients who we have heart rate variability information on, what we see is not only a decrease in overall heart rate variability, but in particular, if you look at the PNN50, which is the percentage of beats over 24 hours that vary from one beat to its neighboring beat by at least 50 milliseconds, and probably the best measure, the RMSSD, which is the root mean square of the standard deviation of that interval difference from beat to beat. We see a pretty low numbers, and these really do seem to, the RMSSD really seems to reflect parasympathetic nervous system the best, quite a bit lower than historical controls. RMSSD has also been shown to correlate, reduced RMSSD has been shown to correlate with higher SUDEP 7 inventory scores. Now, of course, that is 1 degree of separation removed from actual SUDEP. It is a surrogate for SUDEP. And the experience, as was also discussed late this morning, of vagus nerve stimulators in this population to improve heart rate variability by virtue of the high frequency information has been disappointing. And it may just be that we have parallel truths, true, and unrelated. Dravet patients have decreased heart rate variability, and they have increased risk of SUDEP. But whether one is causal of the other is unclear. How am I doing time-wise? Okay, no, I'm just about done. Okay, thank you. I'm going to skip this one anyway. The SUDEP information is lacking, and because of that, we really don't have great information, at least in the Dravet population, of how heart rate variability information can help us. Possible anatomic functional correlation to a low heart rate variability, though, is that we do know in Dravet patients and SUDEP patients in general, there is generally cell loss in the part of the medulla which is responsible for the autonomic nervous system. And we also know that status epilepticus can further damage brainstem centers for cardiorespiratory autonomic pacemaking, as Dr. Laux taught us earlier today. So, and I'm going to end with this, an interesting construct which has been developed in patients with SUDEP, and they have a real control population of epilepsy patients with SUDEP and those who survived. And what they've looked at is it's basically artificial intelligence and machine learning using information from both the EEG and heart rate variability analysis from Holter monitoring using both time and frequency domain information. And using what's basically a logistic regression analysis methodology, they were able, in using all the metrics that I just mentioned, they were able to separate pretty convincingly information using this model of their SUDEP patients from living epilepsy controls with a pretty respectable receiver operating characteristic curve. So one could then imagine in the future that your SUDEP patient comes in every year, and they have, or every 2 years or whatever, and they have their 72-hour EEG, and they have their 24-hour Holter at the same time. The information is fed into this kind of modeling, and then they fall somewhere into a category of high risk versus low risk SUDEP. And then we partner that with the respiratory control data that was discussed earlier today. And then from that, we can start giving families real advice about which of their children's or loved ones require a phrenic nerve pacemaker, or maybe a hyoid muscle pacemaker for obstructive apnea, or perhaps a bradycardia pacemaker for the heart, or an implantable defibrillator for the heart for ventricular tachycardia. Obviously, this is kind of very futuristic thinking, but I think that if we use technology the way some of these high-minded people are, it may help us in the future to not just risk stratify, but actually target the risk stratification into meaningful preventive measures. What we use as our guide in terms of who to put a pacemaker in versus who to put a defibrillator in, that I can't really answer. This is just based upon known cardiac diseases, and the kinds of models that we could use, or the kinds of templates that we could use in terms of who gets a bradycardia pacemaker through or an ICD, is based upon patients with known sinus node dysfunction, heart block, the cardiac channelopathies, the neuromuscular diseases, because that's, after all, that's what Dravet syndrome is, and also patients with cardiac channelopathies who are at risk of sudden death. So that's really all I have, and I'd like to thank everybody for their attention, and happy to take questions. Thanks.
Thank you. Do we have any questions?
In the back?
On the note of heart rate variability, have you seen a correlation of POTS with Dravet patients or SCN1A?
You're asking the right person, because unfortunately I take care of a lot of POTS patients, and the answer is no. In our population of maybe 25 Dravet patients I've seen, I certainly have had a few in whom the family has shown concern about unexplained palpitations and sinus tachycardia. We've had a few who have sort of that purplish discoloration of their legs and a lot of even some peripheral edema, but the actual diagnosis of POTS, I think it's very hard to establish in Dravet patients. In fact, I have found real POTS to be mostly in our patients who are the biggest complainers, and our Dravet patients are not our biggest complainers. It sounds like you have.
I'm an SCN1A mutation myself, and I have POTS. So I'm very curious, based off what you spoke about.
You're my first. Thank you.
I'll answer questions.
How are you being treated for it?
Corlinor.
And has it worked?
Absolutely.
Yeah. Guys, remember this because she's legit. Corlinor is fairly, somebody who's on Corlinor and who carries the diagnosis of POTS, and they've responded, I would say that has verified the diagnosis of POTS.
It's life-changing.
Yeah.
I went from a wheelchair at the beginning of this year to walking in high heels, so.
It's phenomenal.
Yeah.
And you're not a complainer? Is that what I'm understanding? Any other questions?
Anyone else? No? All right. Well, we are going to, first of all, thank you for that great talk. Appreciate that.